And now let's see if we can make some implementation of the great deal of data that we have from Sean. So I would like to present you a case of a patient with non-ST elevation MI undergoing complicated PCI. So this is 70 years old, nice lady called AA. Don't worry, this is not Anna Aronov. Her risk factors include non-insulin dependent diabetic mellitus, treated orally, hypertension, well controlled by calcium channel blockers and beta blockers, and dyslipidemia. Prior cardiovascular history include central retinal vein thrombosis in 2005. She has mild chronic renal failure with mild proteinuria. And other than that, the past medical history includes an event of diverticulitis and peptic ulcer, which is recently non-active. What about the present illness? During the week prior to her admission about 5 months ago to Hashomer, she sustained recurrent episode of epigastric pain, discomfort, accompanied by weakness. She arrived independently to the ER for a similar but prolonged and more pronounced episode of epigastric pain. On admission to the ER, the blood pressure was 160/70, pulse 76 per minute. She was saturating at 98% room air, and the Killip class was defined as class 1. She had left carotid bruit, not surprisingly for an elderly lady with diabetic lady. She had a normal heart sound with a slight systolic murmur of 1/6, heard best in the left sternal border. Lung fields were clear, and so were the other part of the physical exam. This is the first ECG done on arrival to the ER, and as you can see, diffuse ST depression actually over the most of the precordial and the lip leads, as marked by the red circle, slight ST elevation on AVR and V1. The first laboratory test include positive troponin, slightly troponin positive, 0.12. The borderline, the upper normal limit in Hashomer is 0.7. Slight anemia, creatinine of 1.3, and the glucose level was 250. I remind you, this is a diabetic, non-insulin diabetic patient. So she was treated with chewable aspirin and IV heparin, and afterwards the epigastric pain gradually resolved, and the ECG, she was transferred to the intensive care unit, and this was the second ECG done on arrival to the intensive care unit. As you can clearly see, all ECG pathologic ST changes were resolved. I calculate for you her GRACE score, and it was 176, so we really are dealing with high-risk patients. I would like to stop for a moment in this point and ask the distinguished panel what should be the management in this stage, and I would like to remind you or to tell you that at the time of admission to the intensive care unit, it was 10 p.m. in the evening. The patient now was okay. She doesn't sustain any pain. The ECG changes were resolved. And so, David, what should be the next stage on this patient?
Okay, so this is a high-risk patient with a GRACE score of 176, but the patient is stable at the moment. She doesn't have ongoing ischemia. She doesn't have arrhythmias, and she doesn't have heart failure. Based on the guidelines, she should be catheterized within the next 24 hours. I don't think there's room for emergent catheterization. It wouldn't be wrong to catheterize her, but I think it's all right to wait till the morning, considering the information that we have. In terms of the antiplatelet strategy, I would give her aspirin. I would not give her prasugrel for several reasons. First of all, we don't know her anatomy. Her ECG suggests that she has triple vessel disease and possibly left main disease, and that therefore we would not want to give her prasugrel, in which case we would have to wait 5 to 7 days after the catheterization. And also, she had central vein thrombosis, she said.
Correct.
And she might possibly need Coumadin at some point in time, and I would not, in my mind, I would not give prasugrel with Coumadin. I would give clopidogrel at this stage, because I'm not too worried about giving clopidogrel and aspirin should the patient need to undergo cabbage afterwards. I think that we know how to manage these patients these days. I would not give a 2B3 antagonist. We have the acuity timing study. We have ample information that upstream 2B3 inhibitors are not indicated. And in terms of anticoagulant strategy, seeing that I would catheterize her the first thing in the morning, I would probably just give her IV heparin until the morning.
Okay, thanks. Any remarks?
Yes, when I see this diffuse ST segment depression and ST elevation in AVR, the first thing that I think of is severe left main stenosis. That's why I wouldn't put her on anything but aspirin and heparin and take her to the cath lab as soon as possible to rule out left main severe stenosis.
And within 24 hours would be considered reasonable in this patient since she's stabilized.
Yeah, I'd rather have 24 minutes, but 24 hours is okay.
Okay. Sean?
So I agree with the comments. I guess a couple of interesting pieces of information. This patient is at high risk. You mentioned from Grace. Shamir Mehta, when he did his Timax study, the timing of very early versus sort of 24 hours later, the overall result did not show an advantage, and that's why the guidelines indeed recommend that we should try to get the patient, within the sort of 24-hour plus time frame. Although in a subgroup, he did identify that a high Grace risk might warrant, it's obviously hypothesis generating, but might warrant an even earlier time frame. But I agree, if she's stable right now, then the rush. But I would have a very low threshold, even a little bit of pain, because of the concerns of potential left base. It's an ugly looking ECG. One would be very worried. And it is a challenge. I agree that it would be a challenge to get any of the ADP receptor antagonists, even ticagrelor, which binds reversibly. You're still going to be looking at 72 to 96 hours before the antiplatelet effect is worn off. And if this patient needs an early bypass, then that's probably not the most ideal. But I agree with Dr. Hostad that the guidelines would recommend that this patient be considered for clopidogrel. If you are concerned about giving one of these agents, then a short course of 2B3 inhibitor coincident with going to the cath lab, because she's at increased bleeding risk as well, is something to think about.
Okay. So what we did with this patient, we took her to the cath lab the next morning, which was within 12 hours, which actually is in accord with the Timex, because the median time, if I'm not wrong, was 14 hours for the early intervention arm. We did load the patient with clopidogrel. We didn't give the patient 2B3A because we don't believe anymore with upstream 2B3A. And the anticoagulant, as David suggested, we continued the IV heparin. Next morning, the patient was taken to the cath lab. Amit is here. He did the cut on her. And this is the first angiography. As you can see here, we found a severe critical left main stenosis, with even some amount of haziness. And if this is not enough, when we shoot the RCA, there was ostial RCA stenosis. In this stage, we were considering what to do with the patient. We were discussing whether to take her to the OR or to continue with catheterization, but the patient didn't let us to think too much, because she started having the same kind of epigastric discomfort, and even with some STT changes on the monitor. We didn't do an ECG, of course, so the patient was wired and was stented, and this is the final result, which I think is quite satisfactory. So now we were standing with this patient. She was stabilized once again, and we have to ask ourselves once again the same question, more or less, and I would like to stop here once again and ask the panel, maybe I'll start with you, Zaza, what do you think would be the best antithrombotic therapy to support this procedure and how to treat the patient afterwards?
So the first thing we have to think about the patient, the very high thrombotic load in this case, and probably 2B3 inhibitors may be the good policy in this case, and we have to think about what kind of drug to choose, double bolus of integralin or something like this. Maybe another policy we can entertain in this case be to continue with the OZ7 protocol of double dose clopidogrel to transfer to newer antiplatelet drugs, and one of the things we can to choose in this case.
Okay, Sean, what?
Yeah, so in terms of the 2B3 inhibitor, I'm worried about this patient's bleeding risk, but I would consider it here because there is a study, one of the ISAR studies, that looked at non-ST elevation ACS and looked at using 2B3 inhibitor sort of on top of clopidogrel. And in the high-risk patients, troponin elevation, other higher risk features, there was an apparent benefit still of using a 2B3 inhibitor. So I agree with the decision not necessarily to use it up front, but now I would certainly consider it in this patient. In terms of the oral antiplatelet therapy, it's a great result, but I worry a lot about the ostial right, the left main, and so the most optimal antiplatelet therapy I would want to give, at least in the short and intermediate and long term for this patient. And I think this is where in a diabetic who's got stenting, who's just had an acute coronary syndrome, I would want to lean now towards one of the more potent anti-ADP receptor antagonists such as prasugrel.
So what did we do? So we support the procedure, of course, with 2B3. Sorry, okay, Dr. Asali.
I'm happy to comment. It's a very good point. I think just like with ischemic risk, GRACE, TIMI, etc., we should consider in some cases using a bleeding risk score like the CRUSADE score. There's a couple of others that have been developed since that one. The challenge is, for all of us, is that both scores contain similar pieces of information, not exclusively, but a lot of overlap. Older age, renal function, the things that increase the ischemic risk apparently are also associated with the increased bleeding risk. So we have this dilemma, and you're right, if we did a CRUSADE score, I'm sure she would score up there. So that's going to have to be the question, whether we balance the ischemic versus the bleeding risk here. I would think, though, that in this lady, even though the bleeding risk is increased, I would place greater weight on her subsequent ischemic risk. If she develops a stent thrombosis, in her it could be fatal. The chances of having a fatal bleeding is there, for sure, but I would, in this case, not give them equal weight. So it's an excellent point, but in this particular individual, I would give greater preference to reducing the ischemic risk, recognizing I might increase the risk of bleeding, but it's an excellent point.
Sheba.
Yeah, sometimes working in a hospital without any surgical backup makes life much more easier. And so what I would do is just insert an intra-aortic balloon pump and transfer her to Haifa. I think that would have been the best thing to do, and I'm expressing my colleague's opinion. Surgical treatment would be the best option in such a case.
We intended to send her for cabbage, but although we have, as you know, on-site OR, the patient developed severe pain significant with ST changes. Therefore, we decide to stent her.
She was 78?
No, 71. Yeah, but she has osteal RCA too. Right. No, it's not bad at all because the patient is doing very well. That's the most important thing. Anyway, with regard to the antithrombotic, we support the procedure with 2B3A. Although I might tell you that I was surprised to find in a subgroup analysis, an analysis of the ESAR React2, that while most of the benefit was derived from troponin positive, the diabetic patient didn't have at all benefit from 2B3A, but this is a retrospective analysis. I think that it's quite acceptable to support such high risk procedure with haziness in the left main, with patient having pain with 2B3A. Regarding the oral antiplatelet therapy, that was 5 months ago when both ticagrelor and prasugrel were not available in Israel. Therefore, we, according based on the current the PCI cohort of the OASIS 7 current study, we gave the patient 150 double dose of clopidogrel, as you shown in your lecture. Do I like this decision? Would I do the same thing today? Probably not. And I don't, for the interest of time, I wouldn't show you the same slide that you have just seen. But since diabetic patient has clear benefit with prasugrel as compared to clopidogrel, both in non-ST elevation MI as well in ST elevation MI, and in non-insulin dependent as well as in insulin dependent, I think that nowadays I would support this procedure despite the patient according to the probably very high risk for bleeding with either prasugrel or another option as you just shown us with ticagrelor, which is also show benefit over clopidogrel, equal benefit both in diabetic and non-diabetic patients. This is again not a new slide for you. You have seen this slide a few minutes ago. I wouldn't get into it. And the next and the last question I would like to ask is, what should be the duration of the dual antiplatelet therapy? Only a month ago, the Prodigy study was published in Circulation. And what the Prodigy did is that the patients with after standing, with most of them with DES stents, were randomized to either relatively short period of dual antiplatelet therapy for 6 months as compared to 24 months. I have to emphasize this is not an ACS study, but at least 2/3 of the patient underwent the stenting for ACS. What the Prodigy showed is actually that the 25 month as compared to 6 month dual antiplatelet therapy had no even small benefit over the 6 months in reducing ischemic event, but it did decrease the bleeding risk, mentioning the bleeding risk. So I would like to end with asking the panelists, what should be the duration of dual antiplatelet therapy? Should it be 6 months like might be suggested by the Prodigy study, but I would like to emphasize once again, this is not an ACS study. Maybe we have to stay with the 12 month as suggested by many large prospective ACS studies like the CURE PCI, Triton, and Plato, which show continuous diversion of the curves over the year follow-up. Or maybe, since this is a very high-risk patient, a stent, a DES stent in the left main in a diabetic elderly lady, maybe we have to stick with some of the retrospective studies showing that there is some benefit of even longer therapy in patient, especially in diabetic patient and post-DES implementation. David, what would you do?
I think that the answer is in the question. The Prodigy is not the ACS study.
Right.
And I think that in CURE, for example, CURE PCI, the 12-month treatment was given not to reduce stent thrombosis, but to reduce recurrent atherothrombotic events. And because this patient is a ACS patient, a high-risk ACS patient with residual coronary artery disease, and she's prone to develop atherothrombotic events other than stent thrombosis, and I think that she should receive 12 months. I'm not aware of any data regarding 24 to 48
There's
months.
some retrospective studies with all the.
But I would say I would give at least 12 months.
A high-risk patient with the left main bifurcation stenting and ostial right stenting, probably with a durable polymer. If it was a drug-eluting stent with the current generation, it's a durable polymer, which means the polymer will stay there for life. In a patient prone to systemic inflammation, diabetes, in my practice, it's dual antiplatelet therapy for life.
So I agree that there are limitations with the Prodigy trial in terms of its applicability to this patient population, and absolutely the benefit, regardless of revascularization in the post-ACS trials. And I think with due respect, the Prodigy trial is underpowered anyways, especially in a stable coronary disease population. I don't think that we can conclude that because there's no statistically significant difference between those two arms, and the patient sample size was, I think, 900 and in total, or 2,000 in total,
almost
900 in each arm.
yeah.
But still, as large as that sounds, that is not adequately powered to be certain that there isn't a benefit of dual antiplatelet therapy. I understand that the bleeding risk is there, and that's something that we accept when there's a clinical benefit. But I'm worried that Prodigy shouldn't drive us, especially in an ACS population, but even in elective, I'm still not clear whether it's definitive enough, or whether it may have just been underpowered. Otherwise, I agree with all the comments from the two previous commenters.
Two comments. One, remember her bleeding risk, and remember charisma. So in those cases, I think that the middle approach is the best way to go with 12 months. Thank you.
Okay. Thank you very much. And now I will invite Zaza to present a second case